This is Dr. Robert Watkins, orthopedic spine surgeon to professional athletes and creator of the Back Doctor app. Today's podcast is on spine surgery. Does it work? Everybody hears so many stories. They've had a grandmother, grandfather, relative, friend, uncle who's had spine surgery, is still in agony, had 2, 3, 4, 5 of them, still in a lot of pain, some disaster story that is just makes your heart bleed. And so the advice you'll get is never have back surgery. That's been the general consensus statement for the past 50 years. And obviously, if you can ever avoid surgery, do it. But that's part of the reputation spine surgery's had, and for good or bad, some truth, some not truth, but there's been a lot of cases that have really suffered despite having surgery. One of the things nobody ever really talks about is, well, how much pain were they in before they had the surgery? Because remember, the fundamental problem is our spines are falling apart and degenerating starting around age 30. So the fact we're going to live to our 80 or 90, the idea that we're not going to be in pain is really delusional. If you make it to 80 or 90 and you're not in back pain from your spine degenerating, you're actually lucky. But regardless of that, there's no question there's been a lot of people who have had back surgery that are still in pain and still having issues. It's just a fact of the spine, the anatomy, and the limitations to surgery. So you couple this idea of everyone telling you never have back surgery with the fact that a lot of athletes have surgery and go back and play sports afterwards and are highly successful and make millions of dollars. And, Peyton Manning went back, won a Super Bowl after having neck fusion. Rob Gronkowski's gone back several times and won Super Bowls after having back surgery. Tiger Woods is on his way back. So there's all these stories of athletes who have made it back after having back surgery and have been highly successful. So patients get confused because they've heard we'll never have back surgery, but at the same time they see on the ESPN and see in the LA Times that these athletes have surgery and make it back to their sport, and people come in all the time and ask me, well, which one is it? Should I have surgery or not? Because I want to get back to my life and to get back to doing all the things I want to do, running and skiing and surfing, just like these athletes do. But at the same time, I don't want to have back surgery and end up worse and end up needing 2, 3, 4 more of them. So how do we find this middle ground of when can surgery actually work versus when should you never do it? So part of the key, like everything, is it's a mixed bag. One of the questions is, well, why are you having surgery? What's your fundamental pathology, herniated disc, pinched nerve, spondylolisthesis, scoliosis? What's the fundamental problem? And number 2 is, well, how much is it affecting you? How much pain are you in? How much is it taking up your brain power because you're distracted due to this pain all day long? And what about your function? Is it that you can't stand for 5 minutes, or is it that you can't play high-level basketball? What exact function can you not do due to the pain and pathology? And in this regards, I see both ends of the spectrum. I see older people who have spinal stenosis, and after they stand for 5-10 minutes, they start getting pain into their legs and they have to sit down. Well, that's when surgery can really help you. If you can only stand for 5 or 10 minutes, typically we can do a surgery and allow you to stand for 30 to 60 minutes. Well, that's a huge improvement in the quality of life. And the flip side is I also see unrealistic expectations from people. I've had patients who have no pain. They work, they can sleep, they can play with their kids, but when they play basketball 5 nights a week, they get back pain. And they come to me and potentially want to have surgery to help their back pain so they can play in a rec league when they're 40, 50 years old. Well, that's more unrealistic, obviously. So it's hard to generalize. You can't say, oh, everyone should have surgery, everybody should not have surgery. It depends on what the problem is and what your limitation is. And it really depends on what's the quality of your life if you don't have surgery. And if your quality of life is really bad where you can only stand for 5 or 10 minutes, well, surgery has a great chance of really making you better. And likewise, it depends on what have you already done. I mean, if you haven't done anything and you just expect to be perfect and to be pain-free and you're 60, 70 years old, well, you're unrealistic. But if you have done physical therapy for 6 months, you're on a home exercise program, you do it every day, you do cardiovascular exercise 3 days a week, you're eating a paleo diet, you're meditating once a day, you're doing everything you possibly can, and you're still in agony, well, that obviously is a reason to potentially pursue doing surgery because you've maxed out all the non-operative care, so what else is there? The typical results that we get from surgery, and this is pretty well generalized across reporting from other doctors all over the world, is a lot of times people's preoperative pain goes from a 7 or 8 out of 10. And 10 is agony. You can't even see straight. 7 or 8 is really bad all the time. And after surgery, it decreases to a 2 or 3. And I love knowing those numbers because they're good and bad. Where if you're at an 8 out of 10 on an everyday basis and you're in agony and you've done everything and you can't even enjoy your life because you're in so much pain, and if you have surgery and it gets you down to a 3 out of 10, well, that's a good reduction in pain. From an 8 to a 3, that's worth doing. That can make your life worth living again. But at the same time, a 3 out of 10 means most people still average a 3. And what a lot of people don't really understand, it's hard for normal people to understand data because you're not doing it all the time, is a 3 out of 10 doesn't guarantee you a 3. It means that's the average. So some people are at a 1, some people are at a 5. And we don't know as a doctor which one you're going to end up, but the average is a 3. So it gives you a pretty good idea that a 3 out of 10 means you probably still have some pain. And that's where it relates to. If you're at a 3 out of 10 now, before you have surgery, well, don't have the surgery, because the best result of the surgery is typically a 3 out of 10 is what you can expect. So there's no room for improvement. It's not worth the risks of the surgery because there's not enough window of improvement to be worth doing. Whereas if you're in an 8 out of 10, it's probably worth doing the surgery so long as the risks are relatively low, because getting to a 3 is a significant improvement that can really make it worthwhile. One of the hard parts as a doctor is people really want black and white answers. They're so used to saying, well, am I going to be better or not? And is this going to be guaranteed or not? And in our job in spine surgery, there are no guarantees. I mean, there are none in life, but especially in our business, it's a risk assessment. How much pain are you in? What's the chance the surgery is going to help you? What are the risks of the surgery? What's the chance you're going to be better in the short term and long term if you have the surgery versus if you don't? And putting that all in an equation determines whether we go ahead with the surgery or not. But there are no guarantees one way or the other. And it's hard for people to really interpret all that information and make sense of it because they're not used to it and they don't have any medical information coming into it. So our role as the doctor is to try and educate people as much as possible, involve them in the decision-making process, because ultimately it's their decision, but at the same time really help decipher it to put it into terms that can be digestible so that they can make a safe and well-informed decision. So when it comes down to spine surgery, should you have it or not? Well, a lot of it depends on, are you having nerve pain or are you having disc and facet joint pain? Because nerve pain, we're usually pretty successful in treating. You have pressure on a nerve and it's driving you crazy and you can't even see straight, and we do surgery and take the pressure off the nerve. Most people wake up and feel the difference. And that's a great reason to have surgery. And just about every insurance company in every country in the world agrees with that. If you got pressure on a nerve and you have nerve pain that has not responded to non-surgical treatment, almost everybody allows you to have surgery because it's been shown that it's effective for human beings. And the alternative is just suck it up and live with it, which if you've already done that and it's not working, well, then it can be worth having surgery for nerve pain, which is in general arm pain or leg pain, because the nerve goes down the arm and leg. So the more it goes down your extremity, the further it gets away from your spine, and the more it goes down your arm or leg, the more likely it is nerve pain, the more likely surgery is going to help it. And that's as compared to neck and back pain, which we call axial pain. Axial means right in the midline, right up and down your spine. If it's the closer it is to just your neck and your back, the more likely we don't know which one's causing the pain. Is it the disc, the facet joints, or the nerve? Because the nerve starts in your back, so back pain can be nerve pain, but it can be any of those three. It can also be the disc and the joints. And the basic fundamental problem is if you're having pain from the disc and the joints, that's a mechanical fundamental problem. It's degenerative, it's arthritic. It's like having an arthritic knee or hip. That joint is bad. It's painful. And so doing surgery for that is more likely to be a fusion or an artificial disc replacement. But the point is it's more mechanical, it's more reconstructive. We're basically going to take out the disc and reconstruct the disc with an implant, some type of metal, plastic, implant, and that's obviously a much bigger surgery. We're changing the biomechanics of the segment. It's much more invasive, and it has more potential problems as compared to if it's just nerve pain and we're just sneaking in with a microscope and taking some pressure off the nerve and not implanting anything. The microscopic surgery has a better chance of working and a better long-term outcome for the most part, because if nothing else, we're not implanting anything. We're not changing the biomechanics, which always adds some risk and unknown. Now, treating back pain or neck pain, and we'll stick with calling it back pain, which is axial pain, can be helpful. It depends on how bad the pathology is. If you really have a mechanically shot segment at one level and the other ones look great, well, if we go in and stabilize that with screws and rods and we fuse it and stabilize it, it helps people immensely. But it's more complicated because if we fuse that one level and stop the motion, it puts more stress on the other levels, which may already have some wear and tear to them, and then they're more likely to hurt. Or they can start to hurt down the road, 3, 5, 10 years down the road. So back to the nerve pain. Basically, if you have pressure on the nerve, but everything is biomechanically stable, a lot of times we can sneak in with the microscope and just take some pressure off the nerve through a very minimally invasive approach. The incision's an inch or less. Most people go home the same day. Recovery is generally around 2 to 6 weeks. People are up and walking right away. They usually feel like they got kicked in the back, like a horse kicked them in the back, and they're sore for about 3 days. And this is obviously a generalization. Where I've seen people who have no pain, I've seen other people have a lot more pain than I ever expected. But in general, 3 days kicked in the back, a week off of work, they're back doing physical therapy 4 weeks post-op. We do our whole rehab program that's in the Back Doctor app. They get to level 3 of our program. They can go back to all their sports and activities within 3 to 6 months. But the microscopic surgery just takes the pressure off the nerve. It's a great surgery because we're not doing a whole lot. We just sneak in, take the pressure off the nerve, and get in, get out, no implants. The downside is we're not doing a whole lot. We're not changing some of the fundamental wear and tear and degeneration arthritis that accumulates over the years, so you can still have symptoms because of this underlying wear and tear. But basically, there's 2 different types of surgeries for the decompression of the nerves. You know, the nerve is compressed, we decompress the nerve, and it's either a laminectomy or a laminotomy. And a laminectomy has been around for 50 years, most traditional surgery. It's been shown to be safe and effective, works really well. The downside of the laminectomy is you are removing the whole lamina, which is the arch of bone in the back. And the lamina is this bone that connects the 2 facet joints in the back. Well, that provides some rotational stability in your back. So by removing that, you decrease some of the inherent stability, which may lead to more degeneration of the disc and a recurrence of the stenosis and problems that you had. So in our practice today, we rarely do total laminectomies because we want to preserve as much stability as possible. The alternative is a laminotomy, and basically otomy means make a hole in it, whereas ectomy, the previous one, means take the whole thing out. So a laminotomy means make a hole in the lamina. It's kind of a keyhole surgery. We just make a hole in the bone, take the pressure off the nerve, and preserve the arch of lamina, which preserves the stability, which is better for long-term function. And making a hole in the lamina has been shown to not decrease stability because you're saving that arch of bone. Now, I will mention one alternative is sometimes if people's problem is more off to the side in the foramen or a far lateral problem, sometimes we come in at like a 30 to 40 degree angle where the incision's off on the side of their back. I'll come in with a tube and a microscope and open up the hole, take a disc herniation out, and take the pressure off the nerve without doing a laminotomy. We call that more a foraminotomy or far lateral discectomy. And the recovery is basically the same as doing the laminotomy. It's just for a different pathology. So that microscopic surgery is a great surgery. It's the main one we do on professional athletes. We've reported a study where we operated on about 85 professional athletes. We did the microscopic laminotomy and discectomy in 85 pro athletes of just about every sport, and 89% of them returned to their sport at an average of 5 months. And that's the same basic surgery we do on everybody. 80, 90-year-old people, same surgery. It's very bread and butter. and can be highly effective at helping people. But what that surgery does not do, it doesn't treat the underlying fundamental arthritis and degeneration. The way we treat that is basically with our physical therapy program. You get your core muscle strong. By getting the muscle strong, you take stress off the spine and can decrease some of the pain and wear and tear that's occurring on the spine. Now, if the physical therapy and the core strengthening is not good enough because you have a underlying biomechanical problem in the spine, which when the disc and the joints really degenerate, they get sloppy, they lose their structural integrity, the bones can shift in relation to each other. L4 can slide forward on L5 or L5 on S1. That's called a spondylolisthesis, which is a slip of the spine, one of the most common things affecting humans all over the world. So we have a lot of data on that because we see it all the time. Well, if you've got this slippage of significance and this instability and the nerves are being irritated, we know that going in with the microscope and just making more room for the nerve is not very likely to work because you have a biomechanically fundamental problem of instability, in which case we do the fusion. And the fusion can correct the slip and lock it in place with screws and rods and bone and take the pressure off the nerves, which most effectively treats the nerve and stops it from coming back. And the fusions are great. If you have a significant slip and instability, people do fantastic after having a fusion because it treats both. It treats the nerve problem and it treats the fundamental instability through a very safe, reproducible surgery that we do 2 to 3 a week. Additionally, if somebody has a scoliosis, which means a curve in the other plane where holes are closed down and nerves are coming out, they're getting pinched because the holes are closed down due to the curve of the spine and the collapse, doing a fusion, which allows us to open up the holes and to keep it open, can also be highly effective. And so the point is, a fusion can really help people if you have a fundamental instability biomechanical problem, because nothing else corrects that. Chiropractor, acupuncture, laser, decompressive machine, the microscopic surgery, they don't treat a fundamental instability or curve or deformity in your spine. Surgery does, and it's a fusion. Put in screws and rods, correct it. And with the new technology of approaching the spine from the front, the side, the back, using computers to show us the bone three-dimensionally, to put the screws in, all under computer navigation, has made doing fusion so much safer and less invasive than it was 10, 20 years ago that people really do great with that surgery a majority of the time. And again, the results of doing the surgery are about an 8 to a 3. If your pain's an 8 out of 10, and you have the surgery, you get to a 3 out of 10, that's a pretty realistic expectation and can be highly beneficial to the person's quality of life. Now, the one other group of having a fusion is for somebody who just has degenerative disc disease. The disc is painful, and maybe the facet joints are or are not a little bit in the back, but they don't have mechanical instability. There's no slippage, there's no real scoliosis, there's no real pressure on the nerves. It's basically back pain from a degenerated disc. And doing a fusion for that situation has the least successful results. Why? Well, because there's no biomechanical instability. Everything's stable. You know, if you have biomechanical instability, everything's slopping around, and we fuse it and lock it in place, well, that has a better chance of helping somebody because their pathology was worse going into the surgery. Or if they have the nerve pain, that usually helps people too. But if you just have a painful back and a degenerated disc, I do fusions on people for that case, but we have to know beforehand that we have really maxed out the non-operative treatment. And I'm talking about 6 months to a year, doing our whole Back Doctor app, being committed to life and the program and doing all they can to get their pain better without surgery. Diet, meditation, massage, exercise, hitting it hard, hitting everything for a long period of time. But the question is, but what if they're still in agony? What if, and I've got people who are committed, they're doing everything they can, they've changed their whole life to try and help their back, and they're still dragging around. They're still a 7 or 8 out of 10 on an everyday basis because of the pain. The fundamental problem is the degeneration and wear and tear of the disc, and sometimes that is overwhelming. And so then it can be reasonable to do a fusion for that problem. And the results of the fusion have been shown to work. There's studies on both sides of the coin. Some show it works, some show it doesn't. But overall, there are solid studies that show it can be effective for the right reason after non-surgical treatment has failed. And I'll mention in that discussion, there's a million other alternatives to the fusion. There's facet joint replacement, there's spinous process clamps, there's dynamic stabilization, movable rods, artificial disc replacements. There's a lot of other alternatives out there, but nothing really has the track record of doing the fusion. Everything else kind of falls into this middle zone, this gray zone that may or may not work. And I'll explain a little bit of that to you, like an artificial disc replacement in the lumbar spine. If the disc is painful, take out the disc. Instead of fusing it, put it in an artificial disc that preserves motion. So it may decrease some of the stress on the other levels, which is good. The problem with the artificial disc is you still have two facet joints in the back and you have nerves. Well, those may still be painful after the artificial disc because you've only replaced the disc. You haven't replaced those other things. And that pain from those other structures can develop right after the surgery or 5 years or 10 years or 20 years down the road. So if you do an artificial disc replacement in someone who's 30, they got 50 to 60 years to go. They can develop other problems. And the downside of the lumbar artificial disc replacements in your lower back is to put them in, we go in from the front. First time we go in from the front, around your abdomen, it's very straightforward. Things move out of the way pretty easily. But the problem is after that surgery, everything scars down to the front, especially your big blood vessels, your aorta and your inferior vena cava. They can get stuck down to the front of your spine. And the problem is if the artificial disc is painful and needs to be changed to a fusion, going back in the front can be life-threatening because all those vessels are scarred down now, and moving them can be very dangerous. So the downside of the artificial disc, in addition to these other kind of dynamic stabilization systems, is if they loosen or if they become painful down the road, what are you going to do about it? And the backup plan of changing it to a fusion is not always easy. It can be very difficult, and the decision-making can be very difficult. I will mention that cervical artificial disc replacements, the ones in your neck, are generally easier to fix. So if it's not working, going back in the front, we can move your throat to the side and take out the artificial disc and change it to a fusion, typically much safer and much easier than down in the lumbar spine. And that's why all over the world, especially in Europe where these things really started and have been around for 20 years, cervical artificial discs are done much more often than the lumbar ones because it's basically safer to revise them and to change them to a fusion if you need to. So I'll mention one other thing about neck surgery and should you have it or not. We've already established, if you got the pain going down the arm or numbness or weakness down your arm, which is a nerve problem, generally surgery can be very effective. And there's 3 different basic surgeries we do. We go in from the back and do a foraminotomy with a microscope, make a little room for the nerve, or we go in from the front and do a fusion, or we do an artificial disc replacement from the front. And all 3 of those are really good surgery that have excellent outcomes. It's just a question of which one makes the most sense for each specific person's pathology. So nerve issues down the arm, surgery can be very effective. The second category is spinal cord compression. If your spinal cord is being squeezed in your neck, which can throw your balance off or give you jumpiness or hyperreflexia in your legs or in your arms, or cause clumsiness of your hands, that's a big deal. Spinal cord compression puts you at risk of paralysis and loss of function. Just about every surgeon and healthcare provider all over the world agrees in surgery for that because we've seen the devastating effects if you don't have surgery, and surgery can really help preserve your spinal cord function. So that's a whole nother ballgame. That generally, if you're really having dysfunction of your spinal cord and you have real compression in your neck, that's a definite reason to have surgery so long as everything adds up. And then the last group in the neck would be the third category is neck pain. If you have axial neck pain, nothing going down your arms and no spinal cord compression, well, that's when surgery may not be worth doing. Because if we're going to do an artificial disc replacement or a fusion for that, well, you may have pain from other levels and other issues that the surgery doesn't treat. Now, I do surgery for that if we really know what's causing the pain. Like if one disc is shot and the other ones look normal, and we've done all the non-operative treatment and nothing's getting better, well, it can still be reasonable to operate. But for neck pain alone, we really want to know that we've maxed out the non-surgical treatment because so many people hold stress and tension in their neck that a lot of times you need to treat it non-operatively with the diet, meditation, massage, cardiovascular exercise, postural strengthening support to really try and avoid having surgery for that. And so the summary is, does spine surgery work or not? Well, it's a bit of both. One, it depends on what your problem is. The worse your problem is, the more mechanically unstable it is, and the more pressure you have on the nerve and dysfunction of the nerve, the more likely surgery is to help you. But just about with anything, you want to make sure you've also maxed out the non-operative treatment first. And the Back Doctor app has a comprehensive non-operative spine program. It's available free in the App Store and in the Google Play Store. And if we can help at any time, feel free to come in for a consultation.